Just to go ahead and get started before we begin formally, we did want to note that this recording, this webinar will be recorded. If you do not consent to being recorded, we do ask that you drop off at this time. Thank you. All right, welcome everybody to today's webinar, the second in our series. Let me just get my display set up. Welcome to the second webinar in our series on exploring tribal public health infrastructure and capacity. Today we'll focus on tribal public health capacity, or tribal capacity for public health data. Apologies. My name is Nina Martin. I'm the program manager, National Indian Health Board. Just a few notes about today's presentation. We'll talk a little bit in the beginning about a general overview of data for tribal public health, sources, and key issues. We'll then talk about PHICCS 1 and tribal public health data activities reported in our report, and then followed by a guest presentation from the Northwest Portland Area Indian Health Board about the Native Data Project. At the end, we'll have an opportunity for discussion and conversation to hear more from everybody in attendance about this important topic. For those of you who are unfamiliar with the National Indian Health Board, we are celebrating our 50th birthday this year. Celebrating our 50th birthday of being established by the tribes to advocate for American Indian, Alaska Native tribes. You may see some of our team, including Carrie Joseph, who is on today, or see emails about other things related to PHICCS and our infrastructure work over time. So just to start us off, we're curious to hear a little bit more about what you think of when you hear data or when you think of data. And this is interactive, so feel free to use the chat function. You can also use the annotate feature if you hover over the top of your menu. You should see a black button option that says annotate, and you can select the text option. Feel free to type in what you think of when you hear the term data, when you think of data. I see somebody posted information, see some chats, information gathered, population information, sovereignty, power, stories, privacy, sharing, data quality and knowledge, importance, research, tools to make decisions, and people, lives, really centered at what data is centered on. Great. Okay, thank you so much for that. Feel free to keep adding things to the chat as we go. If there are things that you think of or new pieces that are jogged in your mind, I'm just going to clear this real quick. Okay. So first, we want to talk a little bit about data for tribal public health. And just as a backup, for those who may not have been able to join the first webinar in our series last week, just a quick refresher that what we mean when we say tribal public health. We know that tribes have an inherent right to promote and protect the health and welfare of their citizens using methods most relevant for their communities. So when we talk about tribal public health, we're talking about the public health systems that are managed by tribes for tribes. We know too that tribal public health systems can be highly varied and take many different forms based on the needs of the tribes and the community they serve. You may also hear the term community health used. Know that there are a number of players in tribal public health as well. Most importantly, the tribe and the services and efforts they provide, but many others may also be involved in the provision of services, technical assistance, training, or anything else related to providing public health services, including regional organizations, federal, state, local governments, and their related health entities, urban Indian health programs, private nonprofits, and national organizations. So what do we mean when we talk about tribal public health data? And we loved your chats and your messages in the beginning, using really hearing a wide range of what folks think of when we use the term data. So broadly, we think of this as data systems and processes that allow for dissemination of vital information between tribal and non-tribal partners and stakeholders in ways to get timely information related to a variety of areas of importance related to public health, systems to develop evidence base and evaluate ongoing programs and activities. And I do want to note when we talk about evidence base, that is not strictly limited to evidence-based work, but could reflect traditional practices or practice-based knowledge. And this is just a graphic that kind of helps visualize what we think of when we think of tribal public health data systems, which can include but aren't limited to a number of activities related to communicating information out to a community or to partners, collecting and analyzing and disseminating data, however that looks, and methods for evaluation, quality improvement, process and performance improvement. All of those are encapsulated within the tribal public health data system, or could be. And there are certainly other pieces that may not be in here. So just a very brief overview of some current levels of public health data that tribes may access data related to their people. This can include information at the tribal level, for example, internal data systems or other public health information that the tribe may keep, national level or federal information, such as information collected in national surveys, IHS's national data warehouse, or any information related in RPMS. We know at the regional state level, for example, this may include state registries, injury surveillance databases, information also provided by tribal epicenters. And then similarly at the local level, this may be city or county health records if they're providing specific services or support to tribes to deliver public health services. We did want to take a moment to highlight the tribal epidemiology centers, or PHICCS, which you may encounter, or some of you may work for in your work related to tribal public health. There are 12 PHICCS, which were authorized in 1996 by the Indian Healthcare Improvement Act, and they have public health authority, which we will go into, and provide important support and services to advance tribal health and public health. And you can find out more at their website. So we wanted to spend a little bit of time in this early section talking about some key issues for tribal public health data specifically. And this is a short list that NIHB has heard across numerous conversations with tribal leaders, public health professionals, not limited solely to infrastructure, but that appear time and again when we talk about data. We are by no means experts on each of these areas. Many of you work in these lines and experience the challenges that you may face in these issues, but we do want to spend a brief amount of time talking specifically in more detail about the first point, which is recognition of tribal data sovereignty, and by extension, tribal sovereignty. There's also, we know, issues and challenges related to representation in data, specifically around racial misclassification, and invisibility in aggregate data. This links to a policy brief that NCAI has put together, which is really helpful. As well, finally, the third kind of big key issue is access, use, and contribution to relevant data sets. And we'll talk a little bit about this with relation to data sharing partnerships with the Northwest Portland guest presentation. So we want to dive a little bit first into that first item, tribal data sovereignty. And that's kind of rooted in what we talked about earlier, public health authority. So what is a public health authority? This is broadly defined using a definition from CDC as agencies or authorities that provide public health services. So this includes federal public health agencies, and it also includes tribes, tribal health agencies. As sovereign governments, tribal nations are inherent public health authorities, and through the Indian Healthcare Improvement Act, tribal epicenters also have the designation of public health authority. This means that tribal nations and PHICCS can access personal health information for public health purposes. And we do just want to note there's no hierarchy with public health authority. Why are we bringing up this point? Why is tribal data sovereignty so important? It's important because it's the foundation of what should happen, right? It outlines the rights that tribal nations hold with respect to their people and their people's data, and the best practices that should flow from that. We do know that during the COVID-19 pandemic, we've seen recent examples of the ways in which tribes have faced challenges and barriers to have that sovereignty recognized. For example, early in the pandemic, we know there were challenges in getting timely, accurate information related to case counts, to be able to understand what was happening when data was what was needed. I see a message in the chat. Could we share what the act was for PHICCS to get access? That was the Indian Healthcare Improvement Act. So that was just one kind of issue that we really wanted to dive into, and we will go into further information about a larger conversation around public health authority, governance, and tribal sovereignty in next week's webinar, or sorry, not next week, 2 weeks webinar. So we hope you can join us for that. But just a brief overview as we transition to PHICCS and kind of looking at one of the sources that we know for national tribal public health data, which is the Public Health in Indian Country Capacity Scan. PHICCS is a periodic scan to be conducted every 3 years by NIHB. The purpose is to assess the capacity of tribal health and public health organizations for delivering public health services. It's informed by tribes and is meant to provide a national scope. Just briefly, PHICCS 1 was conducted from about 2015 to 2020. There were 134 respondents representing all 12 IHS service areas. You can learn more about the respondents here, or if you access our 2019 PHICCS final report via our website, we highly encourage, if you haven't taken a look at that, definitely spend some time with it. It's a great resource to understand kind of the baseline key issues, priorities, and efforts to strengthen, educate a variety of partners around tribal public health capacity, needs, priorities. So just a quick note before we move further into the data from PHICCS 1, we just want to note that there may be folks here who participated in PHICCS. Tribes own the data, so if you did participate and would like your data back, please send me a private message off this, and we'll work to make sure to get that to you. So, what do we know about tribal public health data activities in PHICCS? The scan asked about 8 different types of data, epi and surveillance, as well as 4 different types of regulation and inspection services. You can see from this overview chart that of those activities, the 8 activities, chronic disease, behavioral risk factors, other communicable infectious disease, data, epi, and surveillance activities, as well as others, chronic disease, data collection, epidemiology, and surveillance, which I will shorten as DES, was one of the most frequently reported activities. And we see items such as environmental illness, foodborne illness, and syndromic surveillance being a little less frequently reported. And as we go to, if you have questions, please feel free to raise your hand, type in the chat, and I can stop and answer those. We'll also have time at the end for discussion as well. So diving in and looking a little further into activities broken down by entity, you can see we see a slightly different picture compared to other public health activities such as screening and education. We know that tribal health organizations continue to be the leader in provision of DES services, but we start to see more overlap with other entities. For example, we see that 69% of tribal health organizations reported that they conducted other infectious disease and communicable DES activities. But we also see that about close to the same amount, 53% reported that state health departments conducted those activities as well. And we can see as well that 38% of reported that local health departments conducted those activities. I specify this one specifically because we know that it may overlap with COVID work related to communicable disease, contact tracing, and recent efforts. But you can also see similar-ish patterns with other DES activities throughout this. We did also want to note that texts are included in the rightmost column, other, along with others, urban Indian health programs due to low numbers. So we know that some of those activities representing work and services supported by texts may be in that column as well. So looking too at another figure, similarly, 47% of tribal health organizations reported that they conducted syndromic surveillance. We see here that 34% were reported conducted by local health departments, and 53% reported that those services were conducted or provided by state health departments. We point this out because these may represent areas where tribes are overlapping, establishing partnerships with entities outside of the tribe, and where data may be exchanging, occurring. I'm sure many folks here have many examples of having to set up partnerships and work and found those relationships, particularly over the last 2 years with the pandemic and the need for data and timely data that we know that has required. So I want to just pause for a second, ask if there are any questions there about these figures. Okay, I don't see anything in the chat. I don't see any hands raised, but just let us know. So also diving a little bit further into some of the workforce and specifically asking about data positions needed in comparison to some of the highest average positions filled among behavioral health staff and administrative and operational staff. We can see that data related positions are overall on average filled in very low numbers. We also know that when asked about workforce development needs, that there were requested needs around training, including on data collection, analysis, technical skills, as well as technical assistance with epidemiology, data analysis, and public health informatics. Oh, I see a question in the chat. Who's the primary respondent for the state health department to describe their epidemiology activities? So with those graphics, it's representing what the tribal health organization who was completing the survey responded, who provides their services. Sorry. So we unfortunately don't know who specifically in the state that would be, just that the state health department is a partner who provides those services. It could be solely provided by the state health department. It could be provided in addition to perhaps activities or work that the tribe is doing, maybe another tribe, another department in the tribe and the state health department. We could go into that in more detail, but we'll keep it at that for today. But certainly if you have other questions, reach out to us after. So then looking finally at one of the final questions we asked in PHICCS was about priorities and needs in general. And what in general that tribal health organizations reported that they wanted support on, specifically in additional resources from the CDC and other federal agencies and states. Expanding this a little bit because it's quite a large table, you can see that data support was in one of the top 7 responses. So, behind funding and training and technical assistance, which we know some of that may include training for data workforce. We know that data support is requested both in additional resources, but also you can see about 11% requested that from CDC, and about 10% are requesting that support from the state. So it points to a need that tribes have in wanting and desiring, prioritizing support for data. So I want to turn the presentation over now to our partners at the Northwest Portland Area Indian Health Board to introduce themselves and their work. And before I put those slides up, I just wanted to check if there were any questions about the previous section before we move into this one. Any questions about PHICCS or the prior sections?
Hi, I have a question. My name is Shasta and I'm calling in from Denver. I was just wondering if NIHB has to complete an IRB proposal to get the survey data from the tribes?
For this one, for the initial PHICCS, we worked with the OMB to obtain clearance, and I'm actually going to see Carrie too if there's additional information there about that, but my understanding was we worked with the OMB for approval. and I can find out more information if needed.
No, we didn't do IRBs for this, as we weren't asking about health information. We're asking about capacity, but we did go through the channels through the Office of Management and Budget to make sure we were in compliance with that.
I can quickly expand on that. So because the PHICCS survey was a volunteer survey and we were not explicitly sharing that data collected publicly, we did not pursue or were required to submit an IRB for review to gain prior approval. So the data belongs to the tribes. We have provided the data collected from PHICCS 1 directly to the tribes who have made those requests and continue to work through those requests at present. So.
Thank you for that question. And I see there's a question about accessing trainings related to data collection and analysis, and see some conversation in the chat. I know many tribal epicenters have also put together a number of trainings as well, which are really good resources. So we will now move over to the next presentation. Let me get that up. Okay. Okay, that should be the correct view.
Great, thanks so much, Nina, and good afternoon, everyone. My name is Sujata Joshi. I'm a project director here at the Northwest Portland Area Indian Health Board. Today, my colleague Joshua and I wanted to provide just some points about some opportunities for tribal public health data infrastructure and capacity in the Northwest. I'll provide kind of a broad overview of some of our current efforts, and then we'll turn it over to Joshua to talk more about a specific resource we recently developed related to public health data sharing. Next slide. And just to, in case you're not familiar with our organization, the Northwest Portland Area Indian Health Board is a tribal health advisory organization that serves the 43 federally recognized tribes of Idaho, Oregon, and Washington. We were established in 1972, so this year is also our 50th anniversary. Our vision is wellness for the 7th generation, and some of our guiding values include supporting tribal sovereignty and looking to traditional knowledge and culture to promote the health of tribal communities in our region. NPAIHB houses one of the 12 tribal epidemiology centers, the Northwest Tech. And I think Nina provided a great overview of who the techs are. Next slide. So at the Northwest Tribal Epicenter, we work to complement and augment the public health efforts of our member tribes. And one of the ways we've been able to do this is through data and epidemiological services. So Nina briefly showed these tech 7 core functions in an earlier slide. All of the techs provide these 7 core functions to either the tribes or urban Indian programs that they serve, though they might do that in different ways depending on the needs of their tribes. But if you take a quick look at these 7 core functions, you can see that data collection, analysis, interpretation, and that translation to action are at the heart of these 7 core functions. Next slide. So over the past several years, and especially during the COVID-19 pandemic, we've recognized that there are opportunities to improve how we support our member tribes with data services. We feel like we've made a lot of inroads with supporting tribes with their primary data collection efforts. We've also made a lot of inroads in terms of addressing some of the data quality issues, specifically misclassification in state surveillance data, which makes the data more usable for tribal nations. But we recognize that we have some more work to do when it comes to providing training and then actual access to data to our tribes. So with funding from the CDC and some support from a couple of consulting groups, we're working to develop a shared vision and roadmap to modernize our data infrastructure. And this work has included getting input from our member tribes and also our staff on kind of that shared vision and hope for outcomes of data modernization. So this slide shows some of our vision and our value statements related to this data modernization work. We all have a shared vision of the Epicenter being able to provide high quality public health data and support to Northwest tribes to promote healthy tribal communities. And some of our values behind this work include data sovereignty, capacity building, and sustainability. Next slide. So we're still in the process of developing our roadmap and those specific strategies to get to that vision, but I can share some of our initial strategies coming out of our data modernization work. Some of it is taking a look inwards to improve our data collection, transformation, and management processes, and then also working to get our staff skilled and proficient in using a core set of tools for data analysis and visualization. A big piece, and we already provide training and capacity building support to our tribes, but really looking to expand that support for data collection, management, analysis, and translation, and then also working to support tribes and enhance utilization of tribally collected data. We're also hoping to expand data access. So one of the strategies we're looking at is developing a data portal that allows tribes to access public health data on their communities, and then continuing to support those data sharing partnerships that are beneficial to tribes. And then lastly, just really looking to continuing coordination and partnerships so that across tribal, state, and federal partners, we're all working together towards that shared vision of healthy tribal communities. So as I mentioned, some of this work is new, but a lot of it continues work that's been going on for many years. And as Nina mentioned, data sharing has been a really long-standing issue in tribal public health. We have developed a new resource that we hope advances some of those conversations and efforts, not just here in the Northwest, but across Indian country. So I'm going to turn it over to my colleague, Joshua Smith, to talk about the Native data sharing resource.
All right. Hi, everyone. I'm Joshua Smith, and I'm going to be talking a little bit about Native data, a data sharing resource for Native people and organizations. Now, we have a lot going on as far as, sharing everything. So I'm going to keep things pretty conversational and, generally at a quick speed. So a little bit about myself. I'm a health communication and evaluation specialist at the Northwest Portland Area Indian Health Board. I've always really had a deep interest in, just kind of tribal data and data issues. I graduated from Portland State University, and a interesting fact is I'm deathly afraid of raccoons. So as far as like a little bit of a background and approach before we go into more of the specifics of our data sharing resource, I just wanted to touch on the background and our approach. So we started this with kind of a foundation of understanding that Native and Native serving organizations really have a strong need for quality health information so that they're able to monitor disease trends, respond to health threats, create informed policies and programs, and uplift the health of their people. Now, the big, what did we do? So we were able to secure about a year's worth of funding to develop a data sharing resource. We compiled or gathered a work group of sort of AIA and data focused individuals from across the US. We really wanted it to be nationally focused as, just even specific regions and tribes have their own kind of unique situations. We didn't require that people were American Indian or Alaska Native, but more so just that they had experience with American Indian, Alaska Native, kind of unique data situations. So we really wanted the data sharing resource to be informed by the work group, and we didn't want to be too prescriptive as far as what that looked like. We wanted to also kind of focus on a strength-based approach that highlighted innovation, as oftentimes, like a lot of resources go into figuring out where things are lacking. And while that is important, it's also important to kind of show the entire story. So we wanted to base this around, current issues as far as Native and Native serving organizations, with the idea that as public health infrastructure develops, these are going to be, I guess, like more highlighted or stronger issues moving forward. So we kind of group these into 3 general categories. Part of that is the increased data needs as tribal public health infrastructure develops. As this develops, there's going to be expanding relationships. And also as far as the unique data issues in Indian country, it's going to really call upon the need for innovation and connecting it what's currently happening across Indian country. We also wanted to kind of gear this towards essentially people who may be interested in data sharing but aren't currently as aware of the process, as there are a lot of specific resources that are geared towards the technical issues. But if you're just kind of coming into this new, it may be hard to really kind of figure out where you start. So that kind of goes into a little bit of the background of like how we decided to start this. So as far as increased data needs, Native and Native serving organizations moving forward may need a little bit of support as far as, really figuring out how do you kind of move from this pipeline of having a question to really operationalizing it, or figuring out how data and analysis sort of relate to that. Also, just the technical aspects of data and data sharing can be very daunting, especially with people who may not have as much experience. So we kind of went into this with this idea that oftentimes people sort of in tribal health find themselves in a position where they may have a strong desire to help their community, but maybe don't know a lot of the technical aspects that are sort of involved in those processes. And also, within this, how do we get people the data that they need, whether that's the actual raw data for them to analyze, or connecting them to resources for people who already have that capacity and may be able to help them answer the questions that they have. So I'll have Sujata paste a link to the website. We kind of broke things up into phases. And for those of you who don't want to, kind of click through, I've kind of copy and pasted a bunch of the website pages. So this is an example of one for, kind of working through the question component and breaking it down into steps. So, really trying to provide resources to how to operationalize the question that you're asking, deciding whether requesting data is even the right approach or the most efficient approach, and really finding that support. Here's one about whether sharing data is a good idea. So a lot of these provide specific resources as far as, certain considerations as far as how to talk to leadership or maybe non-data people about your data needs, knowing your rights as tribes. This is one of the things that our work group really wanted to emphasize as far as, really kind of backing everything in tribal sovereignty, and also, just kind of public health authority status, and really kind of relating that to some of these data issues. So reusing some of the icons, but as far as requesting health data, here is kind of like how we broke down a lot of those specific areas. So as far as relationships, one of the things that, we were sort of made aware of in kind of working through the process with our work group is, as the old adage goes, when you deal with one tribe, you've dealt with one tribe. And I think that this relates a lot to data specific issues. There were a lot of people from state organizations who were really kind of piloting, establishing data sharing agreements with area tribes where that hadn't really existed before. So part of the ability or what we wanted to do with this resource is kind of create something that was able to kind of bridge that level of understanding. How do we kind of help states and similar entities understand the unique considerations of tribes while also helping tribes understand, some of what was involved with, working with states and some of those, kind of regulated entities. So some of this is kind of understanding the process as it exists, how to establish relationships, the importance of kind of getting your foot in the door, so to speak, while also kind of maximizing them for success. So say for tribes, really knowing how to do a lot of your background research so that if you're only able to go to that one meeting and you sort of have to live or die by that, how can you really maximize your face-to-face, interactions with these people to kind of propagate the relationship into the future. And then understand language, because language and specific references can be alienating, but how can we kind of bridge some of that commonality? So here's an example of our building relationships page. There's not as many specific resources as other areas, but this also kind of highlights a little bit of our model as far as not presenting the process as, being linear, because anybody who's worked in data knows that oftentimes you kind of bounce all over the place as things move forward. And this is something that kind of highlights a little bit of the approval process, both helping tribes understand the state approval process and also helping states understand what may be typical in a tribal approval process. We also wanted to highlight stories and what sort of innovation was happening across Indian country, because we all know that issues exist and shortfalls exist, but there are also many great things happening. So how do we really connect these unique stories to other tribes who may be experiencing similar issues? So yeah, we really wanted to highlight these stories throughout so that it's not just a data-focused resource. So here's an example of one of those stories that we created, and this is highlighted within one of our social media posts, but is also an aspect of the website. So through this kind of somewhat long process, we were able to kind of produce native data, which was online, or decided to be online. And we really wanted to provide practical guidance for obtaining and sharing health data while honoring tribal sovereignty, tribal data sovereignty, and public health authority. Overall, we hope that the resource itself is helping individuals who may be interested in requesting health data, building partnerships, developing data agreements, planning for approval, sharing data, exercising data sovereignty, or learning about and exploring their rights. So here's a little bit of information if you're interested in exploring our resource, or also just kind of getting in touch with us as far as, maybe clarifying or providing the stuff that we should add to the resource, because we hope that it's a living, sort of document.
Thank you so much for that amazing presentation. Are there any questions for Sujata or Joshua?
I wouldn't say Miriam, right? No, part of why we wanted it to be national in scope is we really wanted, it to be useful to as many people in different situations as, like sort of what might make sense or be needed in the Northwest may not be needed elsewhere, and sort of vice versa.
Any other questions? Okay. Well, thank you so much to you both. I hope you stick around for the discussion portion, and we can make sure if there are any questions that come up after that, we can get them over to you. The intended audience, I think that might be for native data.
Yeah, so we really focused on it being related to tribes, tribal organizations, and urban Indian health organizations, and then also say state, federal health departments, and essentially who they might be trying to say request data or interact with. We had to sort of narrow the scope. I think the language of the resources are more geared towards, like tribal organizations and urban Indian health organizations. But we really hope that the information that was contained within would be useful to, I guess, both sides. But, as far as tone and language, we had to kind of maybe choose one side to kind of gear it more towards.
Great. Okay, so with that, we will move into the general discussion portion, and similar to last week, this will be just an opportunity for us to hear more about, as folks doing the work, to hear more about what the challenges look like that you faced related to data sharing, data partnerships, any questions or thoughts that may have been jogged by Sujata and Joshua's presentation, or anything else you'd like to share. And this is a conversation. So let me just pull up those questions. Apologies. Okay, so the first question that we have is just, again, you can use the annotation feature, you can use the chat, you can raise your hand if you'd like to speak. Just what have been some of your experiences with any of the key tribal public health data issues that we talked about, or any other ones that we didn't list? And so again, those were related to tribal data sovereignty, and we heard more about that in the last presentation, access and use of data sets, either perhaps data sharing partnerships, or representation in data. We're curious to hear more about your experiences with those issues. Keep an eye on the chat. Okay. Well, if not that, maybe another way to think about that is thinking about your work with data infrastructure, data capacity in general. What are maybe some key barriers that you faced in your work? Or conversely, what are some things that have really helped you achieve what you need to achieve with regards to tribal public health data, building data infrastructure and data capacity?
Just hop in here and maybe provide like some springboards for some discussions. These barriers could include current infrastructure around, fiber optics for consistent and robust internet access, the ability to receive electronic case reports from non-tribal healthcare providers who might be treating tribal citizens, current workforce capacity to put that data to work and use it to inform public health decisions of tribal leadership. So there is really a myriad of current barriers that we know hinder tribal public health data infrastructure and capacity. And so we really would love to hear some of your experiences with these barriers and potentially how you circumvented these barriers and were able to put this data to work to help inform decisions in your community and help to paint a picture of what is going on in your respective communities.
I see some notes in the chat, information security, techs not being given access to state level data for tribal communities that they serve, overlapping jurisdictions and data provided by non-tribal entities not being culturally competent in delivery. Workforce capacity, funding, turnover, and the collection of data in a way that is not useful to tribes. What else? Bidirectional capacity or capability. Losing data people to government and private sector job offers. What other things? Thoughts or perhaps ways that you've gotten around some of these or solutions you would like to see? Mm-hmm. Multi-jurisdictional issues spread over 2 counties and access to COVID data or communicable disease data where the tribe is dependent on the county's approval and authorization. I'm curious, Holly, if you want to share any more ways about how, if there's been things that have worked or to reduce some of that strain and frustration or things that could work.
Sure. So I'm new to tribal public health as of last January, and I come from county public health. So for me, the data sharing and access issue is pretty significant compared to what I'm used to having access to. And so for me, with the Yurok tribe, just simply doing things such as COVID investigations and counseling and having the authority over the reservation has been dependent on the counties that we sit under deeming that we can have access. I think when I first started, I was like, well, this is weird. I'm just going to go to the state. And they were like, yeah, no, you have to go through the county. So one county, because I live in that county and have worked in that county, did give me access to like the state registry, but the other county did not. And so I feel like my reporting as far as the information and COVID cases that are happening is not very accurate, depending on who decides to tell me, and if I, and not to any harm, but just because people are busy and I don't know. And so when I report to my tribal council, it just doesn't feel very concrete, or it just doesn't feel solid, I guess. So that's just, and I'm new, so if anyone has helpful tips. I'm new, I've been here a year, but just the kinks are not completely worked out.
Mm-hmm. Thank you for sharing that. I think that's a really good example of, I feel kind of like what we talked about earlier, of just that the issues with the recognition of tribes' public health authority and the access to that data on their peoples being challenging and getting clear pictures of what's happening in this case with COVID. So we really appreciate you sharing more about that. So another question that we had kind of in the same vein was that what do you see is needed to reinforce or support tribal data sovereignty and really, I guess, reinforce? Miriam says we're in the process of establishing intergovernmental agreement with the County Public Health Department and the tribe to outline data sharing and reporting. I guess too, another way to think of this question, maybe specifically like what education, if that's a piece, or other opportunities, but specifically thinking about maybe education and to whom do we need to really reinforce tribal data sovereignty, public health authority, and how that plays into the necessary systems needed to share and receive data in a timely way. I see updated systems, collaborative data modernization initiatives. Anything else? Data sharing agreements that include strong provisions to protect data ownership. Definitely. Okay. Oh, I see a few more chats. Establishing support for public health authorities, status of techs, beginning surveillance systems for tribes. I think great. We're seeing some information sharing happening in the chat. Okay. So the final question that we had, and this is a big question, but over the next 5 to 10 years, what do you see as new key issues, continuing key issues for the future of tribal public health data? What are the things you think that we should plan for now, or try and address now so that they are no longer continuing to be issues and challenges in 5 years or 10 years?
Nina, someone has their hand up, Tim Collins.
Sorry, yes, Tim, go ahead.
And this is Tim Collins at the Alaska Native Epidemiology Center in Anchorage. One thing that we learned during the pandemic is the tremendous potential that electronic health record data in real time has. We're not really able to make much use out of it. We do some syndromic surveillance with ER data, but for public health and for ongoing surveillance, making use of EHR data in real time would be, I think is where things need to go. At Alaska Native Tribal Health Consortium, we have a shared domain with a very powerful shared tribal analytics group that is demonstrating some of that. So it might be nice to see that expanded, that model expanded across the country. Another thing that we learned during the pandemic, that concerning data, all of our data and all of our comparative analysis that we would do is based on other US states and other THOs, which concerning sovereignty, I don't think is normal. I used to live in Europe, and I think that we're missing a lot of potential lessons learned by not looking to other in-place models that have successfully addressed things like substance use and chronic disease that we haven't been so successful in US models. So an opportunity to, and double that for COVID. So an opportunity to exercise sovereignty by looking to international models is something that I personally would think would be of tremendous benefit. The grant system and the way that we operate, though, really isn't set up to do that. There's no way you can do that. You can't get a grant to go to Germany or Switzerland or Greece to see what they're doing, or if they have this assessment program. So making use of EHR and looking to internationally successful models that could benefit tribal health in the US.
Great. Thank you for sharing that, Tim. I see some other chats about states being compelled to share identifiable data with tribes through legislation or cooperative agreements. Any other thoughts about the next big issues, concerns? Yes, Tim.
As always, 42 CFHR is the restrictions on sharing some behavioral health data can prevent us from doing analysis that is necessary and beneficial. So potential revisions to that or clarifications to that, or legal support in being able to work around it would be useful.
It's an interesting point too around the legal aspect as well, and understanding that. And I know that can be a piece that sometimes we need to expand on. Anything else? Other top comments, questions, concerns, issues that you see really becoming salient over the next couple of years, or that are right now and will continue to be the issues that need to be addressed? Or positive areas of growth. We heard about the increasing use of real-time EHR data being integrated, and we know that increased changes in broadband and IT capabilities and access are going to change the way data is shared and stored and collected. Anything else? Okay, well, of course, if there are things that you think of afterwards, as always, oops, one more chat. Getting more tribal members into data epi and biostats, absolutely. And this overlaps with what we were talking about last week for those who attended, of really strengthening the workforce as a whole. And we saw earlier too about the need to strengthen tribal public health data workforce specifically as well, and the strategies to do that, including through dedicated training programs and support for that. So would love to see more of that in the future. But thank you all for joining us today. Of course, if you think of anything after, questions, follow-up that you have, please don't hesitate to reach out to myself or others, our other staff members on here. We're always happy to hear. We did just want to note that PHICCS 2, the second iteration of the Public Health in Indian Country Capacity Scan, is coming in just a couple months. So keep your ears and eyes open for those notices, and we encourage everybody to get the word out about that. We are actively recruiting pilot participants. So if you're a tribal health director who would like to participate in the pilot, please contact myself, and I'll put my email in the chat, or you can contact any of our other NIHB staff, and we will get in touch. As well, we just want to note that we are currently accepting abstracts for our National Tribal Public Health Summit 2022, and you can submit an abstract in one of 5 topic areas around COVID-19 and vaccines, tribal public health infrastructure, climate change, environmental health, health promotion, and mental and behavioral health. As well, we have a number of programs that will be having upcoming RFAs opening soon, including for GIS. So please stay posted to NIHB's communications. Reach out to me if you have any questions about those, and we'll make sure to connect you to the right folks. So with that, we wanted to say thank you so much for your time today. If you have any questions, please reach out, and we look forward to having you join us for our 3rd and final webinar in the series on February 9th at 3 p.m. Eastern. With that, have a great day. Thank you.